And the nominees are Article 1, presented by Jennifer Rosen.
Invasive pneumococcal disease, or IPD, is a leading cause of pneumonia, meningitis, and bacteremia in children. In March of 2010, a 13-valent pneumococcal conjugate vaccine, or PCV13, was introduced to the routine childhood immunization schedule. We analyzed population-based IPD surveillance data from 2007 through 2012 in New York City children aged less than 5 years and assessed vaccination coverage. The incidence of IPD decreased by 70% after vaccine introduction. Incidence decreased significantly in all racial and ethnic groups. Vaccination coverage with 1 or more doses of PCV13 in children younger than 5 years increased to 90% by 2012. The incidence of IPD in New York City children decreased dramatically after PCV13 introduction, with reductions among all racial and ethnic groups, underscoring the importance of high immunization coverage.
Article 2, presented by Priti Pathela.
It is critical to identify persons at highest risk of acquiring HIV infection in order to better target HIV prevention interventions. Epidemiologic studies and biologic evidence show that syphilis is associated with HIV risk. However, population-based estimates of the incidence of HIV following syphilis infections are lacking. We used population-level syphilis and HIV data among New York City men to quantify HIV incidence following primary or secondary syphilis diagnoses and to identify the highest risk subgroups for intensified prevention, such as HIV PrEP. Leading up to the time of our study and to date, syphilis cases among New York City men had been rapidly increasing, and men remained disproportionately affected by the HIV epidemic. For our study, we matched male syphilis cases reported to the citywide STD surveillance registry between 2000 and 2009 with data on HIV diagnoses reported to the HIV/AIDS registry. Then we measured annual HIV incidence following syphilis and identified risk factors for HIV infection. Our analytic cohort comprised 2,805 HIV-negative men with primary or secondary syphilis, 423 of whom acquired HIV, which represented 15% of the cohort. Overall annual HIV incidence among men diagnosed with syphilis was 3.6%. Annual HIV incidence was high among men who have sex with men, or MSM, at 5.6%. In other words, 1 in 20 MSM was diagnosed with HIV within only a year after syphilis diagnosis. Annual HIV incidence was also high among men diagnosed with the secondary versus primary stage of syphilis and among men who were diagnosed with another bacterial STD after their reported syphilis infection. This latter finding points to ongoing sexual risk behaviors that are associated with higher HIV risk. Implications of our study are that since MSM who are not diagnosed with HIV may not seek care in primary care settings, it is important for healthcare providers to make use of different types of clinical encounters to discuss sexual practices and screen at all sites of sexual exposure. Given the resurgence of syphilis, providers need to be familiar with signs, symptoms, and stages of syphilis and local syphilis and HIV epidemiology. Upon diagnosing syphilis, providers can present population-based findings in as personal a manner as possible and use our data to underscore their messages. Screening is critical, and healthcare providers need to have ways to link patients with HIV risk, such as those with a history of syphilis, to HIV prevention services such as PrEP. Thank you, and a special thanks to my wonderful co-authors.
Article 3, presented by Sarah Johnson.
Extreme heat is associated with increased mortality. With an expected increase in extreme temperature events, identifying vulnerable populations is essential in the development of adaptation strategies. We used a case-only analysis of New York City summertime deaths from 2000 to 2011 to examine individual and neighborhood characteristics that modify the association between heat waves and mortality. Deaths during heat waves were more likely to occur in non-Hispanic Black individuals, at home, among those living in census tracts with higher rates of public assistance and with higher daytime surface temperature. Areas with more grass and trees decreased the likelihood of death. These variables were standardized and combined to create a composite index of heat vulnerability at the census tract level, which was clearly associated with increased risk of death during heat waves. This index is being used by the mayor's office in collaboration with the health department to target interventions, including the Cool Neighborhoods Initiative.
The last article presented by Sung-Woo Lim.
In this paper, we introduced how to assess accuracy of self-reported physical activity data and how to adjust for these errors using a regression calibration method. We used telephone survey data of about 3,000 New York City adults and accelerometer data of a subsample of about 700 survey participants. We calculated the validity coefficient, which is a measure of accuracy and attenuation factors. We also provided a step-by-step instruction about the measurement error corrections. The overall validity of self-reported physical activity measure was 0.19. Ranging from 0 to 1, the validity of our survey measure was quite low. The overall attenuation factors was 0.14, indicating that the measurement errors substantially attenuate association between physical activity levels and health outcomes. Participants with higher accelerometer values were more likely to underreport the actual levels. After correcting for measurement errors, we found that association between outcomes and physical activity levels were de-attenuated. We found substantial measurement errors in self-reported physical activity data. It confirms our common sense, but real contribution of this study is to show the importance of performing a well-designed validation study because it allowed for understanding and correcting measurement errors.